The other treatment option to treat these patients with oligometastatic disease is radiotherapy, and stereotactic body radiotherapy is used, where stereotactic body radiotherapy meaning use of high dose of intense focused radiation to the tumor and minimizing the dose to the surrounding tissues. And you use, it's also called stereoablative radiotherapy, where you use high doses or ablative doses of where you can eliminate all the cancer cells. And this is used in the treatment of, say, metastasis to nodes or isolated bone mets. So I'm showing you a few examples. So this is a patient with prostate cancer who had an isolated nodal recurrence. And you see here, we've given a high dose of radiotherapy to the nodal area here. And the blue areas, this is spinal cord, and we've kind of reduced the dose to the critical structures. And this patient had 3 treatments of 10 gray, 30 gray, and 3 fractions. And when you're talking about conventional radiotherapy, you're giving 2 gray per fraction. And gray is the unit of radiation. It's given over 5 to 6 weeks. But when you talk about stereoablative radiotherapy, you're talking about between 2 to 8 fractions of treatment. And this is another example of somebody with breast cancer, in a 35-year-old who was treated 5 years ago and then came back with isolated met in the vertebral body. And you can see you can give high doses of radiation here and reduce the risk of to dose to the spinal cord. Again, we gave this patient 3 fractions, 30 grain, 3 fractions. So somebody with brain mets, again, this is the brain stem, the eye, the optic nerve, the chiasm, and this is a lesion in the cerebellum. And again, you can give high doses of radiation to these areas and minimal radiation to the surrounding tissues. Because when you have radiotherapy to the adjacent nervous tissues, the damage is irreparable. So you have to keep the dose to the normal structures as low as possible. Again, a patient with isolated brain met. Initially, this was post-stereotactic radiotherapy, and you can see complete response there. Now, assessing response to treatment. So you can assess, when you give any anti-cancer directed treatment, you want to know whether your treatment is effective or it's working. Because these treatments which you offer are quite toxic. So if things are not working, you need to change treatment. So there are various ways we can assess response to treatment. It can be clinical, imaging, tumor markers, or with nuclear medicine scans. Or you can use MRI scans, but I've just given you listed some examples here. So this is an example of somebody with you can assess clinical response to treatment. An 83-year-old lady with recurrent breast cancer. Can you see these skin nodules here? And then she had hormone treatment. She was hormone receptor positive, and she had 9 months of letrozole, and virtually all the skin nodules had disappeared. Can you see this bit here? I don't know if it's projecting well, but it's completely responded to treatment. So this is how you can assess clinical response to treatment. Patient with colorectal cancer with lung mets at baseline and after 2 cycles of chemotherapy. Reduction in response. But often we don't use chest x-rays that often. We use CT scans because sometimes you don't see all the lesions on an x-ray. Use of CT scan to assess response to treatment. A patient with lung cancer, scan at baseline after 3 cycles of chemotherapy and at the end of 6 cycles of chemotherapy. So you can see how the tumor is shrinking. And CT scan is the commonest modality used to assess response to treatment. So when you want to assess response to treatment, you need to have some sort of objective method of assessing response to treatment. It's not really helpful if somebody says the tumor is shrunk, and specifically when you have to run clinical trials and all that, you need some objective assessment because it may not be the same radiologist as reporting it. So there's something called RESIST, Response Evaluation Criteria in Solid Tumors. So what you do is measure target lesions. So for example, target lesions are the lesions where You can see them very obviously on CT scans. It should be at least more than 2 centimeters in size. And what you do is measure the long axis of each of the lesions and add them together. Okay, so you get a number. So that will serve as a baseline measurement. And then you give them chemotherapy, say 3 cycles of chemotherapy or hormone treatment or whatever, and then repeat a scan in 3 months' time. And if the tumor, the length of the tumor shrinks by more than 30%, that means you've got a response. If it grows by more than 20%, that means there's disease progression. But if there's the response rate is less than 30 and less than 20, that means it's stable disease. So that means you can carry on with treatment. So it's quite important to objectively assess response to treatment when you're having anti-cancer treatment. One other example is a choline PET scan. So this is a patient with advanced prostate cancer, with quite a few, locally advanced prostate cancer with quite a few lymph nodes in the pelvis. And this is a baseline scan at diagnosis, where this is an obvious lymph node here, and there are a few other lymph nodes which are not projecting very well. And this is after 6 cycles of docetaxel. So you measure when you talk about a PET scan, you're talking about SUV, that's standardized unit value. And this it was quite hot, so it was about 8.8 or so. And after chemotherapy, you see this is less intense. That indicates response to treatment. So this means they usually talk in terms of metabolic response, and the SUV had dropped to about 5.5. So this is another method to assess response to treatment. Tumor markers are basically biomarkers or proteins which are produced by tumor cells and measured in the blood. PSA is normally produced by benign prostatic tissue, but the levels increase when you have a malignancy. So this is PSA is prostate-specific antigen, which is released by the prostate cancer cells. So this is a patient with metastatic prostate cancer who had a PSA of about 150 or so at baseline. Then you started treatment, that's hormone treatment, and you see how the PSA has dropped nicely. And then the patient had a stable PSA level, low PSA for about 6 to 8 months, and then the PSA started creeping up again. When the PSA starts creeping up again, that means you know that the current treatment is not effective. You might have to change treatment or introduce an additional hormone treatment. So tumor markers are quite beneficial to assess response to treatment. So now is the interactive part. I'd like to make this more interactive. So I'll just go through a few examples, and you can let us know what you think about these. So a 75-year-old man diagnosed with cancer of the prostate is receiving hormone treatment prior to radiotherapy. Excellent. That means you're listening. Second example, 55-year-old man diagnosed with cancer of the esophagus is receiving radiotherapy after surgery as the margins were positive. Good. Example 3. A 34-year-old lady with breast cancer was found to have bone and liver metastasis. She is due to start chemotherapy. Is this... Okay, so this patient has bone and liver mets. So can you cure this patient? So what is this treatment? Excellent. Number 4. A 35-year-old lady with has early stage cervical cancer. She is due to have a radical hysterectomy, bilateral salpingo-oophorectomy, and lymphadenectomy. Is this surgery curative? Excellent. And the last one. A 53-year-old man with locally advanced lung cancer. He is due to have chemoradiation. Both chemotherapy and radiotherapy given together. So who's saying, what are you saying? Okay, so here there are 2 answers. It's radical and it's concurrent. Okay? Great, so that was the end of my talk, but I'm happy to take questions.
So in question number 2, examples.
Yeah, okay. How do you go back? How do you go back? Can you go back? Oh, yeah. Okay, let's see. Here we go. Example 4, example 2.
So, sir, what exactly is the difference between an adjuvant therapy and remission?
Okay. Remission is, say, you've completed the course of your treatment, whatever, surgery, sorry. You've had, say, for example, you've had chemotherapy for a tumor, and then you've been monitoring the patient. The patient enters a phase of monitoring, and then you have scans. You examine the patient clinically, you scan them, and there's no evidence of disease. You do blood, bone marrow. That's when you say the patient's in remission. That is, there's no obvious signs or symptoms of disease. That's remission. Adjuvant treatment is treatment given after definitive treatment. Say, for example, you have breast cancer. You have node-positive breast cancer. You have surgery, which is wide local excision and, say, actually node clearance. Okay, then you have radiotherapy, and then you go on to have chemotherapy. Those radiotherapy is given to reduce the risk of recurrence. Okay, that is treatment. It's part and parcel of the whole treatment. Okay, so so adjuvant treatment, what you're doing is trying to reduce the risk of recurrence, and you may be treating micrometastatic disease, which is not obviously visible. Okay, but you are having treatment. But remission is when you finish your treatment and then you enter a phase of monitoring. That's when you say.
Sir, my question is, when are the biological methods of cancer treatment like monoclonal antibodies, interferons, etc., indicated